Thank you, Wael, and thank you for the organizers for inviting me. No mountains here, just the beach. That's the picture of the Scripps Pier, not more than a half mile from here. But I thank the organizers for letting me talk about cystic fibrosis today and the nexus between mycobacterial disease and this and CF. My funding comes mostly from currently from the CF Foundation, the NIH, and I am a local investigator for clinical trials involving therapy from Vertex. Today, I'm going to talk, it's going to be a basic talk about cystic fibrosis. It's going to kind of emphasize aspects of the disease that might be important for a non-CF bronchiectasis group. But we're going to go over CF, what it is, how the diagnosis is made, some basics about the pathophysiology, and this is going to have a San Diego spin to it. Not necessarily the same talk you would hear if you were on the East Coast, so I'll highlight that as we go. I'm going to talk about some general concepts of therapy and emphasize, because the organizers wanted me to emphasize how these new drugs are working, the modulator therapy, and I'll give you some general concepts on how we're using those. And then the last third of the talk, I'm going to talk about selected aspects of mycobacterial disease in CF. First, I wanted to start with a presentation. This is a 72-year-old that came to our clinic. She did not have the diagnosis of CF at the time, and it was questionable. Half of her physicians thought she had CF, the other half thought that she definitely did not have it. But in any case, she has had problems with progressive shortness of breath over the last year. She could walk about a mile a year ago and now can only walk a couple blocks. In addition, she had problems with cough and sputum production and really a profound fatigue that was just dragging her quality of life down tremendously. She had, kind of relevant to some of the talks earlier this afternoon, problems with a hiatal hernia and reflux disease, and she had some mild heart failure. She reports being very skinny and having problems with fatty food her whole life. Her doctors intermittently mentioned to her that she was pancreatic insufficient, and she also has had problems with chronic sinusitis requiring recurrent nasal polypectomy surgeries. I think overall, though, the thing that was driving her whole health was a chronic airway MAI treatment, which I was not involved with, but this goes back 20 years and has been cared for and managed predominantly by the group at National Jewish. She was recently started on therapy for fevers, weight loss, cough, and shortness of breath, and is currently on clofazimine, bedaquiline, azithromycin, and was recently started on inhaled liposomal amikacin. She's a very thin woman. She had some mild tenderness in her maxillary sinuses, very decreased breath sounds with some rare expiratory wheezing. Her laboratory data was remarkable for signs of systemic inflammation with an elevated CRP and SED rate. And her lung function was about 50% of normal. As far as I've known and as far as I have access to the data in Colorado, she's been basically smear positive all along and grew MAC and MAI. Intermittently, she grows aspergillus and intermittently Pseudomonas and Stenotrophomonas multifida. So I'm going to get back to this case because it highlights a number of important issues in CF and NTM in general. So what is CF? CF is it's a rare disease, about 30,000 people total in the United States, 70,000 people worldwide. It is associated with an increased mortality. Patients born with CF now have an expected lifespan of just under 50 years, and the median age of death in the registry in this past year was 30 years of age. And if I want you to remember one thing about CF, it's all about the mucus, okay? It's kind of gross, but that's what it is. And in the lung, which is the lung disease, which is the primary driver of mortality, the mucus is a critical part of this mucociliary clearance mechanism. And in the disease, it doesn't work, and we get chronic infections. And I want to emphasize that they're, in general, polymicrobial infections. The mucus in the sinus performs a similar function, but the mucus in the biliary ducts in the liver, the mucus keeps the ducts, the hepatic ducts, open, and it protects them from bile acids. And so in the disease with CF, these ducts get plugged up, and our patients get cholestatic liver disease, and about 5 or 10% of them will have hepatic cirrhosis. In the pancreas, in severe CF, the ducts get plugged up, and we get something what we call autodigestion of the pancreas. So there is no pancreas, and it's treated with pancreatic enzyme replacement therapy. In patients with mild CF, they still have a pancreas, and so they can get pancreatitis, intermittent or chronic pancreatitis. Now, the mucus in the lower GI tract in the colon, the mucus in that area serves as a lubricant and just keeps stool moving through. And if you talk to GI doctors who've done colonoscopies, they'll explain the mucus in the proximal colon as almost like a glue-like substance, and so the stool doesn't move. And many of our patients suffer from chronic constipation and occasionally life-threatening bowel obstructions. So it's all about the mucus. The disease itself is caused by variation, genetic variation, mutations, if you will, in a gene called Cystic Fibrosis Transmembrane Regulator. I will call it Cftr for short. It's typically referred to as a chloride channel. In fact, it's more than a chloride channel. It's actually an anion channel, and it transports many things besides chloride, and I want to highlight the role it's going to have in terms of transporting bicarbonate. There are over 2,000 known variations in this gene. 270 of them have been linked to disease, and this number is growing over time. The most common mutation is delta F508. That's a deletion of the 508th amino acid, and as many as 80% of our patients will have at least one copy of that. And to think about this protein, it's a barrel-like structure that sits in the cell membrane, plasma membrane, and it transports these anions, chloride and bicarbonate, but it has this structure underneath that has this regulatory domain or R domain, and normally that R domain is sitting up there right up, and it plugs the bottom of the barrel. And under certain signaling, it drops down below and allows chloride and bicarbonate, whatever, pass through. In a normal situation, that R domain is down, or the channel is open about 30% of the time, and that's going to be important when I talk about modulator therapy. So how do we make a diagnosis of CF? And this is going to be important because I know there's a lot of patients here, and I actually know because of the epidemiology that there's going to be a fair number of you with CFTR variations if it's been checked. In the adult population, and I just got through talking to 2 CF genomicists in the last couple of weeks, this is still a clinical diagnosis, and but the guidelines require some sort of laboratory confirmation, or they really encourage some sort of laboratory confirmation. So the clinical diagnosis is based on that sinopulmonary disease or some kind of GI phenotype, pancreatitis, constipation, cirrhosis, what have you, okay? If you have that and you go and try to confirm, you have a few choices. One are functional studies, so functional studies of the CFTR gene, and by far and away the most common is the sweat chloride test. This is a very operator-dependent assay. In my opinion, should only be done at CF Foundation accredited centers because there's a lot of quality control issues that go in here. So as a provider of adult medicine, I frequently are sending my patients over to our children's hospital who do, I think, somewhere on the order of 5 to 10 of these a day. Okay, so it's very important to get an appropriate lab. The levels that are considered abnormal are above 60 milliequivalents per liter. They're considered a positive study. Recently, they moved the normal limit from 40 down to less than 30 milliequivalents per liter. And then we have that intermediate zone in the 30 to 60 range. Any intermediate or positive study should be repeated at least once, okay? I listed a couple other functional studies, nasal potential difference and a beta-adrenergic sweat test. These are performed mostly at research institutions. So besides the sweat chloride, the clinicians have access to Cftr genetic testing. And the most common test, it's kind of reflexive. There's tiered testing, and most of the services will first test for delta F508, which will pick up almost 50% of patients in North America. If that is negative and the clinician still wants it, they'll do a next step, which starts to assess for 30 to 90. I've seen as many as 180. There's any number of services that provide those. And this number of mutations or search for these mutations will get you up into like the 90-95% range in terms of certainty of identifying all the Cftr variation in a given patient. If the clinician still thinks that this patient has CF and you still might only have one variation, then we are frequently going to full gene sequencing, Cftr sequencing. Again, a lot of commercial labs are out there doing this. They almost invariably are doing exome sequencing, which means that they're just sequencing the coding region of the gene. They're not, and some of the introns, which are more regulatory, but it's not what's considered a full gene sequence, even though they say it is. A number of the services will also do duplications and deletions. This is about 1 or 2% of the population will have a deletion. These are not necessarily picked up in standard sequencing, and they require some specialized services. But these are all commercially available, and you can order those. Now, there are occasionally a need to actually do a full gene sequence where you get the introns and a complete modifier assessment. This is definitely a research tool. It's hard to interpret a lot of these other variations. So those are your choices for laboratory confirmation. And I guess one, how's it showing up? Okay, so one aspect of this is how do we go from a channel that transports chloride and bicarbonate, and how do we go from that to some sort of mucus dysfunction, okay? And here I'm going to rely on our local hero, Paul Quinton. Paul is a professor here. He discovered the chloride ion defect in CF back in 1983. He is the reason why we do sweat chloride tests. He reminds me routinely that about 4 or 5 years after that discovery, he was convinced that the CF pathophysiology had nothing to do with chloride. It was an epiphenomenon, and that everything has to do with bicarbonate, its ability to transport bicarbonate. And I'm going to go through his rationale a little bit here. The idea here, if you can see on the slide, the picture on the upper right, is that mucus, when it sits in the cell, is tightly packed, and mucus has a lot of negatively charged sugar molecules attached to it. And the only way you can get all those negative charges packed together so tightly is you need a positively charged ion, and that's calcium, okay? Now, what happens in the normal situation when there's a danger signal, like a bacteria or an aspiration event, and you need some protection in your airway epithelium, these granules fuse with the cell membrane. This mucus kind of gets out into that luminal area. And if there's not Cftr there pumping out bicarbonate into that area, bicarbonate's pumped into that area that binds up the calcium, and all these negative charged sugar molecules all of a sudden repelling each other, and you get this beautiful deployment of a mucus shield, okay? And in the disease, you don't get that bicarbonate, and so you get aggregated mucus, and then here in the lower right period, you see a chunk of mucus trying to get out of a submucosal gland, and it just can't. It's all stuck. There's too much calcium there. So that's a problem with mucus shield deployment, but there's also a direct effect of bicarbonate on mucus itself, on sputum itself. I just show you here a picture sputum from a CF patient. One was just taken after like a hypertonic saline treatment, and the other one was after inhaling some sodium bicarbonate, and you can see that it actually kind of liquefies the sputum in this situation. And the other really important thing that's just gaining a lot of information about this is the sensitivity of these very important antibacterial peptides. These are very primitive immune system, but they're incredibly efficient at killing any kind of bacteria. And I would say there's data out there now that they're important in killing mycobacterial disease also. But if you lower the pH down low enough, these antibacterial peptides turn off. If you raise it, they turn on, and you have an extra tool to fight the chronic infection. It's hard for me to talk about CF without talking about the ecology of the microbial community there. There's a lot of information on here, but I just wanted to emphasize that these infections, particularly in CF, and it's going to be hard for me to believe that this is not true in bronchiectasis or NTM in general, but these are polymicrobial infections. And the ecologists like to talk about two kinds of communities. One is more transient, it's an attack community. Another is a more prolonged, not necessarily permanent, but a long-lived community, the climax community, which includes all the classic CF pathogens, and I'm going to include mycobacteria in this climax community. So here's a summary of the pathophysiology. You have a defective gene with low CFTR activity, some sort of abnormality with anion transport, and we get this mucociliary clearance deficit, and you get set up for chronic infection and inflammation, which causes the permanent airway damage, which we call bronchiectasis. So how do we treat this? And I swear the speakers in this room did not get together before and share slides, but I've been doing this for 30 years right now, and I can just tell you it's all about airway clearance. And in CF, in San Diego, we have nice weather, we have beaches, we tell people to get out and exercise, work up a sweat, give me 30 to 60 minutes of good exercise. I realize that my older patients cannot give me 60-minute beach runs every day. So anything else that was highlighted earlier, airway clearance with vests, frequencers, we're starting to use active cycle breathing, things like autogenic drainage, and also a lot of other techniques, these devices like the Acapello and the Aerobica. So once you have a good base airway clearance program, then we can talk about things like hypertonic saline, mannitol, recombinant human DNA. So a lot of these were talked about earlier today. Inhaled antibiotics as suppressive therapy and oral and IVs during exacerbations of this. We're relatively sparse in the anti-inflammatory region, but it is a focus in the pipeline development. Eventually, down the line, we're hoping to get gene therapy, which is going to happen in the kind of context of DNA editing or RNA editing. We're told by the leadership, the research leadership in the CF Foundation, that the timeline for DNA and RNA editing is probably probably going to be around 15 years or so if everything goes well. In the meantime, we're kind of going to be dependent on what we're calling modulator therapy. And so I wanted to talk a little bit about that. So modulators are small molecules, orally bioavailable, that we're going to use to improve the CFTR activity in CF patients or patients with CFTR variation. And think about this. You've inherited a gene from your mother and your father, and it's the combined activity of both genes, the output of both genes, that is your total CFTR activity. You can break that CFTR activity also down into the amount of, or the quantity of CFTR molecules. That's how many individual molecules you can get to the membrane. But you can also assess of whether those molecules, those very mutated molecules, whether they have activity or not, how much function they have. So we talked about that door opening and closing. So on some of these mutations, the door is just slammed shut all the time, okay? And we have other mutations where the channel itself is deformed, and so the conductance or the movement of chloride or bicarbonate through that channel is defective and is not as high as it should be. So it's the combination of the two, the numbers and actually the activity of the molecules that are important. And to take this a little bit further, is this graph shown here, because it's the total amount of CFTR activity that's going to determine the clinical phenotype or the clinical manifestations. There's a lot of us in this room here that are going to be carriers for CF mutations, and that's going to put you somewhere in that steep part of the curve, but that steep part of the curve is not associated with measurable disease unless you're at the tail end, at the bottom, okay? So if you're running at 50% of total CFTR activity, you're going to have some allergic sinusitis, you might have an occasional episode of pancreatitis when you go out partying, but you're not going to have any problems with bronchiectasis long term. People with 2 double deltas, the most common mutation, are going to be on the right side of this graph. They're going to be running at around 2 or 3% of normal activity. So what does modulator therapy do? So we have a number of modulators already out there. The first one that came out is in the middle. It's called Cftr. And Cftr basically increases that open probability of the channel. It moves it from about 30% up to around, I'm told, 85 to 90%. And it works not only on mutated CFTR molecules, but it actually works on normal, wild type. So I could give any normal person here some Cftr, and they might well sputter for a day or two until they reach a new equilibrium, but the open probability of their CFTR would increase dramatically. So that drug came out in 2012, and it works well and it's FDA approved for certain gating mutations, which are spelled out in the label. But like I said, it also works on wild type CFTR. Over the last 2 or 3 years, we've had some new therapies called the correctors that have come in. There's 2 correctors that are currently on the market, Cftr and Cftr. Both of them are specific to the delta F508 variation, mutation. Okay, they don't work on other mutations, just the delta F508. So we have, so this therapy is combined, so the corrector is typically combined with a potentiator. So what happens is that the corrector therapy gets more of the barrels up to the cell surface, and then Cftr opens up the door more, okay? So they work together in synergy. So we have 3 FDA-approved therapies, modulator therapies currently. Cftr monotherapy for CFTR gating mutations, such as G551D, and then we have a number of other residual function mutations that we're using this in. The corrector, the combination of corrector and potentiator therapy, we have 2 of those out. They're good for double deltas and also for delta F508 and 1 residual function. I'm going to show some data that was recently published on Cftr. This just came out in last November. This shows the lung function improvement in a double-blind, placebo-controlled study. It was 6 months long. It showed a sustained effect on lung function. And not only did it improve lung function, it was found to be safe. It decreased the number of pulmonary exacerbations. There were no change in BMI, but it also improved patients' symptoms. Concurrent with that was a second trial. It was shorter, just 2 months long in this case, but it was Cftr, and this was in patients with 1 delta F508, and the second mutation had to have some residual function, so a less severe mutation. And they had 3 arms. They looked at placebo, Cftr alone, which was working on that residual function mutation that they had, and then when you added Cftr to the combination, you got even a bigger bump in the lung function. This combination was also found to be safe. It improved symptoms and also decrease or improve the sweat chloride study. So let's go back to our patient. She had a very good workup done elsewhere. She had some PCD data that was kind of interesting and provocative, but really didn't amount to much anything as far as I can tell or anybody else involved with her care. She had a sweat chloride of 25, which was under that 30 range. She had a borderline nasal potential difference and some CFTR variations, M470V, which if you look up in the literature is quote unquote not a disease-causing mutation. And then she had some variations in this 5T allele, which is a splicing efficiency mutation. Her fecal elastase was low, consistent with pancreatic insufficiency, which is what we find in classic CF. So the way we put this together is that I actually did call her that she had CF because of the strong clinical phenotype. She did not have convincing laboratory confirmation with some caveats that I'm going to go over. She had chronic aspiration and this chronic 20-year-old airway infection. I actually think that she's suffering from multiple hits, and that's why probably she has bronchiectasis. So our strategy with her was to maintain optimal airway clearance, and as Chuck emphasized, really try to improve her nutritional status. I'm just hoping that the National Jewish People don't cut back on her therapy right now because as of a couple hours ago, I just got her approved for some Cftr, which we hope to start on Monday or Tuesday of this week. The company gave us the Cftr on an individual IND because we called her CF and because they have internal data that says this M470V mutation is not normal. It has about 50% of activity. She's a homozygote for that, so she's running like a carrier. And then you add this 5T allele onto one of those, and she's back down at the bottom of that curve on the right side. She'll see she has very little total CFTR activity. The goal of this ivacaftor therapy would be to stabilize or improve her lung function and hopefully facilitate the mucociliary clearance. And if I hit a home run, hopefully can eradicate her MAC biofilm, but we'll see. So this is a nice segue to talk, just in the last part of this, some selected topics on mycobacteria and CF. I have not done this work. I'm going to be quoting people's work who are in this room. But generally speaking, it's a problem. And this data here is from the most recent registry, which shows about 13% of CF patients have it. I think this is underestimating it because I don't think people are culturing enough for mycobacteria in this disease. In any case, there's a general feeling that the incidence is increasing. MAC and M. abscessus are the most common species. We tend to see MAC in patients with milder CF, kind of like our patient that I presented, and we see a lot of M. abscessus in more severe, younger patients. And it's associated, recent studies have come out that says it's associated with accelerated loss of lung function. There's a lot of geographical variation in the United States. The 4 bars on the left, you can't read this too well. 4 studies, this is by a review by Dr. Kwan, I think, showing that in North America we see a lot more MAC than we do M. abscessus, but in Europe it's the other way. They see a lot more M. abscessus. And then there's 2 studies on the right show Israel has even different kinds of NTM than Europe and North America. There's been a lot of other studies on the geographical variation in here. I got to just do a hats off to the NIH group, Dr. Edjimian and Olivier and Winthrop have done a wonderful job looking at giving us an idea of where this is. And I'm just taking one figure out of several very good articles showing that the correlation between atmospheric water vapor, climatic connections with the prevalence of NTM. And they conclude that atmospheric conditions explain more of the variation of the disease than individual behaviors. So this is in contrast to this study which I could not give a talk about CF and NTM without bringing it out. I don't hang out in these NTM circles, but I imagine this caused a lot of discussions. Basically, this was a study of around 1,000 genomes of Mycobacterium abscessus subspecies and across the world. And basically, they found 3 major clusters, okay? 2 in M. abscessus and 1 in Macillians. So most of the patients had something in one of these 3 clusters. These clusters were associated with chronic infections, increased antibiotic resistance, and worse clinical outcomes. And I think this study, from my read of it, provided very strong genetic evidence that these tightly related isolates can be spread between individuals. And a lot of them did have epidemiology suggesting that it was being spread through either some fomite or some external surface or long-lived infectious aerosols in care settings. But one of the things that left me empty about this, but there was a huge number of these very highly related mycobacterial isolates, and they had no plausible connection between them, okay? And in the article, they mentioned that there was probably some alternative human zoonotic or environmental vector that about covers everything. So it left me kind of empty. I was hoping, I was looking, I thought I might have missed it, but I didn't. I was hoping that these investigators would have taken a bunch of non-CF or some non-CF disease controls from the same lab or same region, and just to let us know how closely those non-CF patients, because there's an implication when you read this paper, they keep using the word spread and transmission, and you get this sense that there's a big party going on that I didn't know about. Okay, I'm almost finished here. So why is there a connection between NTM and CFTR? Well, we know that in non-CF NTM, about 30 or 50% of the people who are carriers carry this. Mycobacteria have this metabolism that can be supported with a slow metabolism, and in hypoxic conditions, the envelope is hydrophobic, which allows connection to the airway epithelium. The innate response can be inhibited. We talked about the low pH and the antibacterial peptides. And I'm also fascinated, because I do a lot of genetic ecology, about the potential metabolomic or metabolic symbiosis between fungal species and mycobacteria. And also, with the sequencing that's coming out, we're seeing a lot more horizontal gene transfer between standard CF pathogens like Pseudomonas and mycobacteria, so they're exchanging genes that allow them to survive in this harsh environment. So I'm not going to go into treatment. It's dealt with elsewhere. I just want to highlight that there's a big overlap between the symptoms and the radiography between CF and non-CF mycobacterial disease. I think Chuck and other speakers have mentioned that we treat the comorbidities first, treat the pathogens, treat the standard pathogens, treat the fungal pathogens, optimize sinus disease, GERD, and diabetes. And if you do all that and the lung function is still declining and the exacerbations are still occurring, then go ahead and treat, okay? This is my last slide. My pharmacist made this up. As we bring more and more of these modulator therapies in, we're finding out that there's a lot of drug-drug interactions, particularly with those involved with NTM treatment. And like I said, there's a lot of detail here. My advice to you is to consult a good pharmacist who's familiar with all this, which is what I'm doing. So in summary, CF and the NTM patient physician communities are starting to recognize the importance of NTM. The clinical trials are finally starting to occur on how to treat CF and CF-related NTM, and I got to get my, again, hats off to the Denver group for taking leadership in this role. I wasn't here, but hopefully there's some new antibiotics being developed, maybe? No? Okay. So anyways, my last point is very, very highly speculative, but I'm hoping that somebody takes an interest. There is a rationale for looking at this modulator therapy in non-CF bronchiectasis if patients have certain variations in their CFTR. And this is really far out, but bacteriophage therapy, which I don't have time to go into, but there are a number of groups that are looking at these viruses that kill bacteria, including mycobacteria. And I can tell you we have a fledgling bacteriophage institute here, and mycobacteria clearly is on our radar screen, probably in the 3 to 5 year time range. So I'll leave that. I'll leave you this. This is I don't know if anybody recognizes this place. This is North Island, right here, that little spit of land out here. The convention center's over there on the left. This is a picture of a woodcut from the first TB sanatorium in Point Loma in San Diego. So I'll stop there, take any questions.